Dear colleagues, 25 years ago, Professor Christian von Ilberg reported that it is possible to do a cochlear implantation and to preserve or partially preserve the preoperative residual hearing. Moreover, he showed that patients could benefit from the combination of then acoustic hearing combined with electric hearing. And so EAS, or electroacoustic stimulation, was born. Members of the hearing group. The hearing group is a global platform network of 31 comprehensive cochlear implant clinics that joined forces on the field of cochlear implantation. Members of the hearing group have been also focusing a lot on EAS over the years. And today, I will present you the latest publications and findings of the hearing group on EAS, and published, or will be published, in 2022. First, let's speak about the indications. At the right side, you see the audiogram, and initially the cross-hatched area, pink cross-hatched area, was the initial indication for electroacoustic stimulation. Afterwards, with improving results, the acoustic field was expanded to the red area on the audiogram. The black line is a typical audiogram that we see in Belgium, for instance, as good candidates for EAS. And since 1 year, we can also get reimbursement for this type of hearing situation for electroacoustic stimulation. Of course, these indications vary quite a lot from land to land, but scientifically, it is insisted that you should test also the patients in the best aided condition, and the patients should be at least worse than 60% monosyllabic score at 65 dB SPL. The advantages are widespread in audibility for the patient. We know that low-tone acoustic hearing is important for form-mental recognition, hearing the difference between male and female voices, for instance, and especially also for prosody and rhythm. And by combining this with the electrical stimulation, and that you see at the right upper side is the result from the first international EAS study done in 2005 and 2007, published 2008, you see the improved speech recognition in noise from EAS in comparison to electrical stimulation only, but also many publications, and we show at the lower panel in Science the result from the group from Professor Büchner and Professor Lennartz, where also it is clear that at the left side you see the electroacoustic performance of speech understanding, even in quiet, in comparison with electrical stimulation at the other side. But also there are reports of better subjective benefit using the AFAP, better natural sound, better music appreciation. We developed over the years refinements of the surgery. And with the hearing group, a survey was done to see whether the opinions changed from 2010 until now. Already in 2010, there was an agreement on corticosteroids pre-op, post-op, and topically during the surgery. Only now in 2018, when the survey was done, there was more emphasis on this corticosteroid treatment. All patients should also be treated with antibiotics. It is important that we preferentially use round window insertion. We have to avoid perilymph aspiration once the round window is open or the cochliostomy is open. We have to flush the bone dust away so that we do not induce additional conductive hearing loss. Also, the importance of slow insertion of the electrode less than 1 millimeter per second is emphasized over the years. Also, everyone feels that the dedicated ES surgical training is necessary for surgeons starting with this type of surgery. And there was a unanimous advice to use flexible straight electrodes, but we come back on that. What changed also in these years, that there is emerging importance to measure the size of the cochlea and to make accordingly the choice for the proper electrode size and length. And also emerging is the interest for place-based mapping. That means that not just the default frequency allocation for each electrode is used, but that we specifically allocate frequencies to the different electrodes in relation to their real location, following whether Greenwood or whether the spiral ganglion map. And at the right side, you see a recent publication of the University of North Carolina, where you see the results of speech understanding in the different speech to noise conditions. And at the right side, when the default electrode frequency allocations is adapted really to the place-based frequency. And it is clear that there is a better speech understanding in this condition. Moreover, over the years, it has been proven that there is a better vestibular function conservation when we do this type of surgery. There is also speech recognition improvement, also in profound hearing loss. And at the right side, you see with the black bars, the patients where the electrode stays nicely in the scala tympani, and the gray bars where the scala tympani pierces through the basilar membrane and ends up in the scala vestibuli. So this is not conservative surgery, and that the results are better when you respect the organ of Corti. And so we speak now not only about hearing preservation surgery, but hearing and structure preservation surgery. And last, importantly, for the future, when you respect the organ of Corti and the basilar membrane and do not induce inflammation in the cochlea, you preserve the organ of Corti for maybe later molecular biologic therapy. We can also quantify the amount of acoustic hearing and preservation of the acoustic hearing. Everyone can find this Excel sheet and do their calculations themselves by going on the hearing website, going to VR research tools, and then the hearing preservation calculator. And then you can fill out your own audiogram preoperatively, and then you will see it as a dashed line in the audiogram, and then the post-op results as a full line, and then the system calculates the proportional loss of residual hearing. And we call hearing preservation complete conservation when the is less than 75% and 100% conservation. We don't call it partial when it is between 25 and 75% conservation, and then minimal or loss if it is less than 25% conservation of the hearing, of the acoustic hearing postoperatively. And we will use this formula later on. During the opinion, everyone was choosing for flexible electrodes, but is this supported by science? So we did a very exhaustive systematic literature review on electrode characteristics, and we compared straight electrodes with pre-curved electrodes. And we analyzed the publications on 3 major electrode location problems. It is the electrode tip fault over, the electrode scalar deviation, and the electrode slippage. All 3 have a tremendous influence on the outcome of speech recognition. And we included in this study, which is published a few weeks ago, 83 studies comprising 8,655 cochlear implant surgeries, 4,900 pre-shaped, 3,700 straight electrodes. What do we see? On electrode tip fault over, pre-shaped electrodes have a tip fault over of incidence of 5.38%. It is 10 times more than with the straight electrodes. When we look at the electrode scalar deviation, where the electrode pierces through the basilar membrane and ends up in the scala vestibuli. The pre-shaped electrode has an incidence of scalar deviation of more than 28%, whereas for the straight electrodes, it was only 11%. So for both very deleterious effects, the straight electrodes far outperforms the pre-shaped electrodes. But when we look at electrode slippage, also something we don't want to happen, we see that the pre-shaped electrode stays better in place in the cochlea, only 0.5% that there is a slippage from the electrode out of the cochlea, or for some electrodes out of the cochlea, whereas in the straight electrode, it occurs in 3%. So that makes that if you choose for a straight electrode, you have better preservation of inner ear structures, but the surgeon has to pay particular attention in fixing the electrode, especially at the level of the posterior tympanotomy. Now, we analyzed how deep we have to insert the electrode, where the insertion depth has an influence on hearing preservation. And for that, we did analysis only with the flexible straight electrodes of Medel, the Flex 24, Flex 28, and the Flex Soft. We found 25 publications and 300 patients with the Flex 24, and we found 15 publications and more than 70 patients for the longer electrodes. And the main difference is when you choose for the Flex 24, what we call the medium length electrode, then you're sure that you have a stimulation for the full basal turn. But when you choose for the Flex 28 and the Flex Soft, with this length, also taking into account the variability of the sizes of the cochleas, you're sure that you can stimulate in the second turn. And for a while, it was said that maybe you should use shorter electrodes to have a better hearing preservation. But when we look now at the results, and let us look at the left panel, you see the results of the shorter electrode and the longer electrodes, and the hearing preservation rate for both is between 87 and 92% hearing preservation. I recall again, hearing preservation, we call it complete and partial. That means from 100 to 25% conservation of the hearing preservation. And there is no statistical difference. So choosing for longer electrode is not deleterious for hearing preservation. When we make the difference in the longer electrode between the 28 and the 31 millimeter, also here we do not see a difference. It is a retrospective study, so that means that probably surgeons have taken into account the size of the cochlea. And what about then on complete conservation? Because that's interesting. Well, of course, complete conservation is less good. It's between 35 and 40%. But also here, we do not see a difference between the Flex 24 electrode and the longer electrodes. Also in this graph, you see the black and gray bars. This is measured at 4 months and at 12 months postoperatively. And within this period, we do not see any difference. An element we have to consider is, of course, the progression of the hearing loss. Immediate hearing loss after cochlear implantation on the average is 25 dB on the low tone pure average. It's 125 to 500 Hertz. And afterwards, at a longer follow-up time, and publications that deal with that show that there is a progressive decline between 2 and 9 dB per year. And the study in our center in Antwerp showed that it is 3% of the surface value per year over a period of 10 years. So although we have very high hearing preservation rates, defining that there is afterwards useful acoustic hearing, on the long term, it will decay, and we have to find a solution for that. Is a solution deeper insertion? Well, then we have to be convinced that deeper insertion of the electrode gives also better speech understanding. And is there rationale for that? Yes. Recent scientific work has shown that about 25% of the spinal ganglion neurons are located in the second turn, apically between 400 degrees and mean of 650, 680 degrees. So if you stimulate only the basal turn, you miss a quarter of the spinal ganglions to be stimulated. And psychoacoustic tests in different centers showed that in order for a patient to hear low tone with electrical stimulation only, and low tone is under 400 Hertz, you need to use electrodes in the second turn beyond 450 degrees up to 600 degrees. And on top of that, stimulating at the frequency of the acoustic signal. So that means fine structure stimulation in the apical electrodes. So that's the scientific basis. If you look at the different studies, this is a prospective study for the University of North California. It's quite clear that also, and they proved it at 1 year, and afterwards they published the results at 4 years, that the medium electrode is performing less good than the longer electrode. With longer electrode, your speech recognition is superior in comparison to these medium electrodes. And from the same group, they further analyzed difference between 28 and 31 millimeter, and the percentage correct. You see there's even with further deeper insertion, even improvement in speech understanding. And they found that there is an improvement of speech understanding, but to a certain plateau, a maximum insertion angle around 650 degrees, between 600 and 700. There's a plateau probably, but this corresponds quite well with the apex of the spinal ganglion bulb, which is located around this angle of insertion. So we come to the conclusion of these different studies that with the hearing members we've performed, analysis we've performed, preserved residual hearing enhances the audibility of cochlear implantation. Hearing structure preservation surgery has to be applied in all cases of cochlear implantation. All those with profound hearing loss, they will benefit from it. Straight flexible electrodes are the least traumatic to the cochlea, and longer electrodes have the same hearing preservation rate as medium electrodes. And moreover, we see that speech recognition improves until angular insertion of 650 degrees. And so I come to my main conclusion from this series of studies, and that is, we ask you to consider longer electrodes, 28 and 31 millimeter, when you do an intervention for an electroacoustic stimulation. Then, of course, the electrode overlaps largely the region where you can do acoustic stimulation. But in case that the hearing is lost, you have immediately a deep electrode. In case the acoustic hearing is okay, then you can deselect the apical electrodes, and is acoustic stimulation, acoustic and electric. But you have to look also at the studies, how much overlap is necessary. And in case the acoustic hearing over time decays, then you don't need to do a new surgery, a new intervention. Then your electrode is in place to get optimal electric acoustic stimulation for good speech understanding, also for the low tones. And further in the future, we look about the ongoing progress on the application of cochlear size and choice of electrodes, the application of this for the place frequency mapping of what is also called a synonym anatomy-based fitting. And in the near future, because the studies are running already, drug-eluting electrodes might keep better hearing preservation, and also the place of robotic-assisted CI surgery that has now already proof of concept proven, might also contribute to better electroacoustic stimulation. I thank you for your attention.